So today we will learn about the oral hypoglycemic drugs, and these drugs are the one which lower the blood glucose level, especially in case of diabetes mellitus, and they are, as the name indicates, they are effective orally. But the important drawback of the insulin is it must be given by injection. That is, every day we need to give it by the injection route. That's why it is the disadvantage. Whereas the orally active drugs have always been sought. That's why, because every day it's very difficult to take the insulin injections, and that's the recurrent pricks, etc. So unless and until it is unavoidable, then it is not so compulsorily. So in this regard, the oral hypoglycemic drugs have been invented. So the first drugs are the sulfonamides, especially not the antibiotic sulfonamides or antibacterials, or these are the groups. They have what you call as the descended in the 1940. So they produce the hypoglycemia as one of the side effects, and that side effect is taken as the effect. And the first clinically acceptable sulfonylurea, that's the tolbutamide, was introduced in 1957, and others followed soon after. So in the 1970s, so called second generation sulfonylureas were developed, which are having the potency more than 20 to 100 times than that of the earlier drugs. So the clinically useful biguanide penformin was introduced parallel to sulfonylureas in 1957. So all this is a very brief history, because we should know when the drugs have been developed very effectively towards the diabetes mellitus, and the newer approaches have constantly been explored, and the thiazolidinediones or meglitine analogs, alpha glycosidase inhibitors, and the latest are the dipeptidyl peptidase 4 inhibitors are the recent generation this oral hypoglycemic drugs are concerned. Then the classification is the sulfonylureas, especially they are the KATP channel blockers. Please remember this particular classification. The number one is the enhanced insulin secretions, the agents which enhance insulin secretions. So here it comes as the sulfonylureas or KATP channel blockers. Once again, here we can give the example of the first generation drug, that is tolbutamide, whereas the second generation drug is the one of the well-known drug, that's the glibenclamide, or it's also known as glyburide, glipizide, gliclazide, and glimepiride. All these are the second generation drugs among the sulfonylureas, whereas the drugs like the meglitine phenylalanine analogs are also there. That's the second category. The example is rapiglinide and nataglinide, whereas the third category is glucagon-like peptide 1 receptor agonists. To repeat once again, glucagon-like peptide 1 receptor agonists. So these are the injectable drugs. The example to this category are exenatide and liraglutide are the examples of this category. And the fourth and the recent generation is dipeptidyl peptidase 4, or they are also known as the DPP4 inhibitors. And here the example are the sitagliptin, that's the vildagliptin, saxagliptin, alogliptin, and linagliptin. All these are the drugs which are the DPP4 inhibitors. So the classification you need to remember, and this is the classical example of all the drug. So that's the first category. A is enhanced insulin secretions. All these are the subclassifications: sulfonylureas, meglitidinide or analogs, then glucagon-like peptide GLP receptor agonists and dipeptidyl peptidase inhibitor DPP4 inhibitors. Then another is the B is the second one is to overcome insulin resistance. So in this particular thing there are two classification. One is biguanides, or they are also known as AMPK activators. The example is the most popular drug in case of diabetes, that is metformin. The second one is the thiazolidinediones or PPARY activators. They are also known as the PPAR gamma activator. So the example is pioglitazone. Whereas the third category or the C, or which are not coming under the classical category of these drugs, is the miscellaneous anti-diabetic drugs. Among them, the first one is the alpha glucosidase inhibitors. Alpha glucosidase inhibitors. Example is acarabose. Then another example is miglitol and voglibose are the examples. The second category in case of the miscellaneous anti-diabetic drugs is the amylin analogs. The example is pramlintide. Then the third category is dopamine receptor agonists like the bromocriptine. So sodium glucose cotransporter 2 or SGLT2 receptor agonists. That's the dapagliflozin is the example of this category. And coming to the first agents, there is the sulfonylureas are one of the oldest classification of the drugs, and the generic formula of the sulfonylureas is looking like this. Then this is a benzene ring with R1 because this is going to change these SO2, NHCOR and R2. There are two rings are there which we can modify and get so many other products. So all sulfonylureas have the similar pharmacological profile. Their sole significant action belonging lowering the blood glucose level in normal subjects and type 2 diabetes, but not in case of the type 1 diabetes. So these are all the insulin secreting agent enhancers. So being more potent, clinically superior, only the second generation sulfonylureas are employed now. The first generation compounds have been discontinued except tolbutamide, which is infrequently used nowadays in the clinical practice is concerned. Then coming to the mechanism of action of the sulfonylureas, maybe the first generation or the second generation is concerned. So the sulfonylureas provoke a brisk release of the insulin from the pancreatic beta cells, and the rate of insulin secretion at any glucose concentration is increased. That is, insulin release is provoked even at low glucose concentration. That is, the risking production of severe and unpredictable hypoglycemia is also there. Especially in case of type 2 diabetes mellitus, the kinetic of the insulin release in response to glucose or meal is delayed and it is subdued. So whenever the person is hungry, then in type 2 diabetes, if he is having type 2 diabetes, then kinetic of insulin release in response to the glucose or meals is delayed. So delayed onset of the response is seen. The sulfonylureas primarily augment the second phase of the insulin secretion with little effect on the first phase. so that they do not cause hypoglycemia in the pancreatomized animals. And in type 1 diabetes especially, at least there should be presence of 30% functional beta cell, which is essential for that is the action, and it confirms their indirect action through the pancreas. So a minor action reducing the glucagon secretion also reduced, and the probably by increasing insulin and somatostatin release has been demonstrated. These agents, especially the sulfonylureas. Then the hepatic degradation of insulin is also slowed, because after the production insulin will act on the receptors, and during the circulation it will get trapped in the liver and get metabolized. So that process is also slowed. Then apart from this one, the extra pancreatic actions of these agents are the after few months of the administration. So what happens? So many days of the administration, the insulinemic actions of the sulfonylureas definitely is going to decline. The reason is due to down regulation of the sulfonylurea receptors, or they are also short termed as SUR1s on beta cells, but improvement in glucose tolerance is maintained. Means, so after the 2 to 3 months or 4 months or the prolonged use of these sulfonylureas, the concentration of the receptors on the tissues will be drastically reduced. That's called as the down regulation of the receptors. So, but improvement in glucose tolerance is also maintained. So in this phase, these sensitize the pancreas, these target tissue, especially liver, to the action of insulin. They make the liver to respond more and more to the release, and this is due to the increase in number of insulin receptors, a prospector action improving the translation of the receptor activation. So it is going to activate the receptor, and then it increases the hypoglycemic activity. So it is hypothesized that long-term improvement in carbohydrate tolerance leads to overall lowering of calculating insulin concentration, which reverses the down regulation of the insulin receptors. So what happens is, because of this thing, an apparent increase in their number also occurs, especially all the receptors. So direct extra pancreatic actions means, apart from the pancreatic, the sulfonylureas to increase insulin receptors on target cells. So this is also important, especially the population of the insulin receptors on target cells will be increased, and to inhibit gluconeogenesis in liver has been thought, means but appears to have little clinical relevance, even though it is thought to that there is increase in the receptors of population over the target cells, and to inhibit gluconeogenesis in liver it is proposed, but the role of this action is under doubt. And coming to the pharmacokinetic, in very short, I am going to tell all these kinetics etc. in very short. So the all sulfonylureas are well absorbed orally. Please remember that all sulfonylureas are well absorbed orally and are 90% or more bound to plasma proteins and have low volume of distribution, low VD, that's 0.2 to 0.4 liters per kg, and they are primarily metabolized. These products, when taken orally, as the name indicates, oral hypoglycemic drug, they produce the active metabolite, and the metabolites, sometimes they may be active or sometimes they may be inactive. they are totally excreted in the urine. So that's the kinetic pattern. As such, they should be used cautiously in the patient with the liver or kidney dysfunction as usual. So we have to use most of the drugs with kidney and liver impaired persons with caution. The dose and other things should be adjusted properly, not to induce any toxicities. So drug interactions, there are varieties of the drug interactions to the sulfonylureas. So drugs that enhance sulfonylurea action may precipitate the hypoglycemia. So they may be increased, especially hypoglycemia is caused due to overaction of the insulin. So what happens is there is an interaction between the drugs which can increase the hypoglycemia. So what happens is, number one, displace from protein binding. These are all the drugs which displace the sulfonylureas from protein binding, that is phenylbutazone, that's sulforaphane, salicylates, sulfonamides. All these drugs will displace the sulfonylureas from protein binding site, and the B is another, the inhibit metabolism and also the excretion of the drugs. So the ketoconazole, an antifungal drug, and sulfonamides, the antibacterial drug, warfarin anticoagulant, chloramphenicol, an antibiotic, then acute alcohol intake will inhibit the metabolism and excretion of the oral hypoglycemic drug, and because of this thing the hypoglycemia may result. And another example is given, that cimetidine. I have crossed this because the cimetidine is not in human use. Yes, maybe the reason for the cimetidine to be banned in the human use is it induces the gynecomastia, especially in case of the male, and synergize with or prolong pharmacodynamic action. The salicylate, propranolol, that's the cardioselective beta-1 blockers, are less liable, and also the sympatholytic antihypertensive, then lithium, theophylline alcohol. All these are synergetic with the sulfonylureas, which prolong the action, mechanism of action of, or the pharmacodynamic of the sulfonylureas, so that the duration of action of the drugs will be increased, especially sulfonylureas, and ultimately the result is inhibiting the gluconeogenesis. So these are all the drugs which increase the action of the sulfonylureas, especially which prolong the action or potentiate the action and all these things. Whereas certain drugs may also decrease the sulfonylurea action. So that the vitiate the diabetic control. So the example are the metabolism enhancers, means induce metabolism. The example is the phenobarbital sodium. It is also a anti-epileptic drug belonging to the category of barbiturates, phenytoin. Then the anti-epileptic drug rifamycin, which is a anti-tuberculosis drug, and also the chronic alcoholism. They will induce the metabolism of sulfonylureas, so that the action will be reduced to a drastic extent. And the opposite action of suppress the insulin release are the cortisones, then thiazide type of the diuretics, then also the loop diuretic, the furosemide, and also the oral contracepting agents, and all these are going to decrease the action of the sulfonylureas. Coming to the adverse effect in one or two lines, the incidence of adverse effect is very low, that is just 3 to 7%. Means these drugs can be safely administered, especially in the human beings. And coming to the first one, that is the hypoglycemia, is one of the most commonly seen in most of the insulin administration or also the oral hypoglycemic agent administration. So the hypoglycemia is also one of the very commonly seen or the particularly oral hypoglycemic drugs, they are going to increase the concentration of the naturally occurring insulin. Then so the number one side effect, especially in the oral hypoglycemic agents, is the very common problem is hypoglycemia. So it is common in elderly liver and kidney disease patients when potentiating the drugs are added. So if you add the certain drugs like the sulfonamides or the ketoconazole or many other drugs which potentiate the action of the hypoglycemia drugs, then the liver and kidney disease patients with the impaired liver and kidney, then it is increased. The tolbutamide carries lowest risk due to its low potency and short duration of action. And the treatment of hypoglycemic episode is to give glucose, may be for few days because the hypoglycemia may result. So this is also another important thing. And non-specific side effects are the majority of the antidiabetics started on sulfonylureas tend to gain the weight. That's the one of the important thing. There is weight gain in most of the persons who are under the treatment of oral anti-glycemic drugs. So the reason of this is their insulinemic action. That is the what you call as the catabolic effect of the insulin. That's also one of the side effect what we can say. So this may be a consequence of the hyperinsulinemia, nausea, vomiting, flatulence, diarrhea or constipation. Headache is also one of the side effect, and paresthesias are gently mild and somehow they are not so common. And hypersensitivity rashes, that is photosensitivity, purpurea, transient leukopenia, and rarely agranulocytosis is also a common. And flushing and disulfiram like a reaction. What is disulfiram? Disulfiram is a aldehyde or alcohol dehydrogenase enzyme inhibitor which converts the alcohol into aldehydes. So the flushing and disulfiram like actions after alcohol is reported to occur, especially in some individuals taking the sulfonylureas and drink the alcohol. So this side effect one need to be careful. And tolbutamide reduces iodine uptake by the thyroid, but hypothyroidism does not occur. And the safety of sulfonylureas during the pregnancy is not established yet, and change over to insulin is always advised if it is not responding to the oral hypoglycemic drugs. Then the sulfonylureas are secreted in milk and should not be given to the nursing mothers. And chlorpropamide is one of the first sulfonylureas which has been discontinued because of long duration of action, more than 2 days, and frequent hypoglycemia. So the few of the drugs which belong to this category induce the hypoglycemia, and hence they are discontinued. And one example is chlorpropamide, and it was also prone to cause dilutional hyponatremia by sensitizing the kidney to anti-diuretic hormone, and also the cholestatic jaundice and alcohol flush. All these are some of the side effects, especially when we are using sulfonylureas for the anti-diabetic effect. And important features of the oral hypoglycemic drugs are here. The classifications you can go through very thoroughly. The number one is the tolbutamide, the preparations, the rastinon, and the plasma T half or half-life is 6 hours. Then the duration of action is 6 to 8 hours sulfonylureas. Whereas the clearance route is the liver, and the daily dose is 0.5 to 3 grams, and number of doses per day required is 2 to 3. And this is a weaker, short-acting, flexible dosage, safer in early and those prone to hypoglycemia. Whereas the glibenclamide or it's also called as glyburide. So it's also very commonly available as dionyl tablets, because many patients use this particular tablet. And euglycone bentanase are available. The plasma half-life is just 2 to 4 hours, and the duration is 24 hours. So duration of action is 24 hours, and the dose is 2.5 to 15 milligram per kg 1 to 2 times a day. It is a very potent but slow acting, the glibenclamide, and higher incidence of there is hypoglycemia chances are there, and the single daily dose dispute short half-life due to the active metabolite and sequestration of the beta cells. Whereas the glipizide is also available as glycinase or gluid or mini-diab. So many it's available in the form of the 5 milligram tablets. The plasma half-life is 3 to 5 hours, duration of action is half day. Then the daily dose is 5 to 20 milligram total dose, and 1 to 2 doses are required per day. Then another drug is the gliclazide. So it is available in different trade name. Of course, the plasma T half is 10 to 20 hours, and the what you call as the duration of action is 12 to 24 hours. That means we can say that this is long acting. And the total dose is 40 to 240 milligram, depending upon the blood glucose concentration and the diabetic stage of that particular person. And faster and shorter acting, higher daily dose need to be divided. The hypoglycemia and weight gain are less likely to occur, especially by the gliclazide. And another drug, that's the fifth drug, is glimepiride. So the trade names are there with different trade names, and it's available as 1 or 2 milligram tablets. So the plasma half-life is 5 to 7 hours. Once again, just like the glibenclamide, the duration is 24 hours, and 1 to 6 milligram is the total dose which need to be given as 1 or 2 times a day. And the glimepiride is another example which is having the plasma half-life of 5 to 7 hours. Then the duration of action is also 24 hours. Whereas the second category is the meglitinide or phenylalanine analogs. The example of this category are rifaglinide, which is having the plasma half-life less than 1 hour, whereas the duration of action is 3 to 5 hours. The daily dose is 1 to 8 milligram total, whereas the neteglinide is the plasma half-life is the 1.5 hours and 2 to 4 hours is the total duration of action. So the DPP4 inhibitors are the examples of this category are sitagliptin. So they are available as Jano 100 milligram tablet, and the plasma half-life is around 12 hours and the duration of action is 24 hours. Then the total daily dose is 100 milligram, a single dose. Please remember that it is a single dose because the half-life is long here, the duration of action is long. And vidagliptin is another agent which is having almost all the similar property. The next category is the biguanides. It's one of the most commonly used drug like metformin. So biguanides is the metformin. So glyciphage or the glycomet are not two trade names if you want to purchase this for the study purpose. Then the plasma half-life is 1.5 to 3 hours. Total duration of action is 6 to 8 milligram. Then the clearance route is through kidney. Then 0.5 to 2.5 grams is the total dose, and it need to be given 1 to 2 times a day. So here no hypoglycemia is seen, no metabolized lactic acidosis is seen, but only in case of the kidney diseases it may be seen. And the pioglitazone is also known as the pionorm, and many more preparations are available. The plasma half-life is 3 to 5 hours. Total duration of action is 24 hours. Then the dose is 15 to 45 milligram once a day. That's enough because the duration of action is 24 hours. So it may improve lipid profile, reverses insulin resistance, and also the hypoglycemia. So this is in detail about the total property of almost all the drug. And coming to the first drug, that's the meglitinide or the DPP4 analog, or they are also known as KATP channel blockers, potassium ATP channel blockers. And these KATP channel blockers with a quick and short last acting insulin action. The first agent is rifaglinide. And this meglitinide analog oral hypoglycemic agent is designed to normalize the mealtime glucose excursions. So it is an analog of oral glycemic and designed to normalize the mealtime glucose assertion. And it is not a sulfonylurea, it acts as an analog manner by binding to SUR, that's the sulfonylurea, and closure of ATP dependent potassium channels. So that's why they are called as the KATP channel blockers. And ultimately depolarization occurs and the insulin will secrete. So the rifaglinide is quickly absorbed and metabolized very fastly. So it induces fast onset of short insulin release. So it's a insulin releasing agent, especially rifaglinide. So here you can see that rifaglinide is having the following mechanism of action. So this is a cell wall, and the rifaglinide is going to act on the specific receptor, especially rifaglinide receptors. Then what happens is the potassium, calcium efflux will be there. Because of this thing, ripaglinide causes the ATP dependent potassium channel close. Then depolarization occurs. Then intracellular calcium influx will be increased, and this leads the insulin secretion. So the whenever the ripaglinide is going to bind with that of the receptor, then the ATP dependent potassium channel close is activated, then depolarization occurs, then it increases the calcium influx, and ultimately the insulin, which is stored in the secretory cells, is released into the blood stream. And because of this characteristic, it is pattern, it's of use in different from that of the sulfonylureas. So the ripaglinide is administered before major meal to control postprandial hyperglycemia. So the dose should be omitted if a meal is missed. That's a very important thing. A person suffering from diabetes mellitus, if he takes the tablet of the ripaglinide, then and by oversight, because of the work stress and other thing, he misses a lunch, definitely he will undergo the hypoglycemia. And because of the short lasting action, it may have a lower risk of serious hypoglycemia, and the side effects are moderate headache, dyspepsia, arthralgia, and weight gain. Most of the agents, the side effect of oral hypoglycemic agents is the weight gain, and ripaglinide is indicated only in selected type 2 diabetes who suffer pronounced postprandial hyperglycemia, or to supplement the metformin long acting insulin. So it should be avoided in liver disease. So in case of liver disease, it should be avoided, because the liver is a organ which catabolizes or metabolizes this particular drug ripaglinide, and it should be avoided, because as the metabolite passes into the blood stream without any change, because especially in case of liver, then it may go and act on the specific receptors and cause the hypoglycemia. The another example is nataglinide. It is a D-phenylalanine derivative which principally stimulates the first phase of insulin secretion. So how it's going to cause that particular action is closing beta cell KATP channels, resulting in faster onset of action and shorter acting hypoglycemia than ripaglinide. So this is advantage of this drug over the ripaglinide. Nataglinide is a superior drug when compared to ripaglinide. So ingested 10 minutes before the meal, it limits the postprandial hyperglycemia. Means after lunch or the dinner or the food, it limits postprandial hyperglycemia in type 2 diabetes without producing late phase hypoglycemia. So this is very important, because most of the sulfonylureas, they cause the hypoglycemia and make more and more insulin to be secreted. But this drug is having the lack of such adverse effects, because there is a little effect on the fasting blood glucose level, and episodes of hypoglycemia are less frequent than the regular sulfonylureas. The side effects are like dizziness, nausea, flu-like symptoms, and joint pain will be seen if the dose is more and more. So it is used in type 2 diabetes mellitus along with other anti-diabetic drugs to control postprandial rise in blood glucose. So whenever the person is suffering from diabetes, depending upon the complications, etc., 2 or more antidiabetics may also be prescribed. Hence, this is to control the postprandial hyperglycemia. So here is a the pictorial or type of the diagrammatic representation of a cell which utilizes the glucose for the energy source. So here whenever the insulin channel is going to be bind with that of the any other drug or insulin or any other drug, then the glucolysis will take place. So the pancreatic beta cells they get stimulated, then inhibition of the action takes place, and the ATP sensitive potassium channels are going to open, and it causes the depolarization. Then the voltage dependent calcium ions get activated, and the vesicles which are having the insulin moieties, they will be fused together, and release of insulin take place. So this is the diagrammatic representation. And glucagon like peptide 1 receptor agonists or GLP-1 receptor agonists are also important drugs, and it is an important incretin released from the gut and responsible to ingested glucose. So what happens is incretin is secreted from the intestine, and it induces insulin release from the pancreatic beta cells, inhibits glucagon release from the alpha cells, and also slows the gastric emptying, and the suppresses the appetite by activating specific GLP-1 receptors. And these are cell surface G protein coupled receptors expressed on the beta cell and the alpha cells both. Hence, the central and peripheral neurons, gastrointestinal mucosa, etc., they are getting the effect. And characteristically, GLP-1, that's the glucagon like peptide 1, includes the insulin release only at the very high concentration, especially the incretin system appears to promote the beta cells, its health, as well as the failure of the incretins has been implicated in the pathophysiogenesis of the beta cell dysfunction of the type 2 diabetes, which is very common in the human being, and particularly progression of the disease. And GLP-1 based therapy appears to be the most effective treatment for preserving beta cell, that's the function in case of the type 2 diabetes. So whenever the prescribing a drug to a patient suffering from this diabetes, then the doctor need to think several times whether I can go for the sulfonylureas or the GLP-1 receptor analogs or many more drugs. So that's the choice of the physician who treats the patient. So here you can see that in the stomach there will be gastric emptying with the GLP-1 proteins will be there. So the effect of these GLP-1 proteins is the increase in cardioprotein production, and cardiac this output is also regularized, whereas on the gastrointestinal tract, especially the stomach, the cells will be present, especially the islets langerhans in the pancreas. So this cause the decreased gastric emptying time, means the food is going to store more and more in the stomach, whereas the islets, the synthesis of the insulin takes place, biocell proliferation, then the beta cell apoptosis. So programmed cell death or apoptosis will take place whenever it is acting on the stomach, whereas the Insulin resistance can occur because of the insulin secretion and both the glucagon secretions. So this will affect the liver. So if the first action blocks, then the glucoma production will be a common phenomenon. GLP-1 itself is not suitable for the clinical use because rapid degradation by the enzyme or dipeptidyl peptidases 4, or they are also known as the DPP4 inhibitors, and these are expressed on the luminal membrane of the capillary endothelial cells, especially on the kidneys and liver gut mucosa and immune cells. These are all the places where the GLP-1 receptors are present. So another incretin, glucose dependent insulinotropic peptide, or it's also known as GIP. So this also induces insulin release, but in human beings it is the more important incretin, and the GIP means glucose dependent insulinotropic peptide has poor action in case of the type 2 diabetes, whereas the GIP receptor is detecting from the GLP-1 receptor, but it mediates mostly the similar responses to the drug. And nowadays, because of the advancement in the medical science, more and more stable analogs of the GLP-1 receptor have been produced for the intended clinical sign in case of the type 2 diabetes. GLP-1 receptor agonists are, the first category is the human glucosylate P, GLP backbone, then exendin, then it is having the exendin 4 is the backbone of the action. So what happens if it is given like doluglutide, that's the dimeric DPP resistant human GLP-1 genetically fused into the FC domain of the IgG4. Then the liraglutide, it analytical GLP-1 analog, then acetylation slows for the association with albumin, that's the T half is 23 hours, whereas the extendin 4 blockade backbone causes, that's the exenatide BID, then synthetic expedin 4, and the peptide 50% homologous to the human GLP-1 and resistant to DPP4 degradation. So another drug is the lexinatide, that it is a synthetic exceptin 4, its C-terminal modification adding 6 lysine residues and removing 1 proline will make it more potent. So the externite QW is another thing, externite encased in microspores, which slowly hydrolyze the release of the particular drug, whereas the albiglutide is another drug which is a DPP4 resistant human insulin. The GLP-1, that's going to dimer, genetically fused to human albumin. So the next drug is exenatide. Exenatide is another drug. It is a synthetic DPP4 resistant analog which activates the glucose-like protein receptor and produces the same response to the earlier drug. Then it is a peptide, it is orally, it should not be given, it is inactively exenatide. Exenatide cannot be given orally. So it need to be injected just like insulins, and its half-life is less than 3 hours or equivalent to 3 hours, not more than 3 hours, and the duration is action 6 to 10 minutes. It's also very short acting. So it's marketed in USA, UK, Europe, or mainly as the add-on drug to the metformin or the sulfonylureas, or a combination of this pioglitazone in poorly controlled type 2 diabetes. So the benefits noted are the total lowering of the postprandial as well as the fasting blood glucose, glycosylated hemoglobin, and the body weight is lower. The most important side effect is nausea and vomiting in about the 50% of the patients, but tolerance develops later. Unlike the tolerance develops to the sulfonylureas, it is very rare. So this is the chart which includes the action of the different drug which are going to activate the GLP or GIP to inactive peptide. Then the DPP4 antagonists like sitagliptin, vidagliptin, it is going to inhibit the conversion of GLP1, then also the GIP to the inactive peptide. So other reactions are other drugs, they are going to bind with the different places on the cell surface of the cells, especially the receptors. The sulfonylureas, then the maglitide analogs block sulfonylurea receptor 1, which constitutes a subunits of inwardly rectifying ATP sensitive the potassium channel, or it's also called as the KATP in the membrane of the pancreatic beta cells. And also the inward flow of potassium is thereby restricted, intracellular potassium concentration falls down, and the membrane is partially depolarized, augmenting calcium ion channels and opening as the release of calcium from the intracellular cells stores. The calcium ions promote the fusion of insulin containing intracellular granules with the plasma membrane and exocytosis release of the insulin. So this is about the oral hypoglycemic drug. So tomorrow we will see about the incretins and other drugs which are also acting on this particular cell. So with this we are going to end today's class.